Hey y'all, this is lab 3, and we're going to go over the conduction system of the heart, electrocardiography, blood vessels, blood pressure, and pulses. So during exercise 31, we will talk about the intrinsic conduction system of the heart, look at depolarization and repolarization and how they're represented on ECGs or EKGs, and learn about different cardiac arrhythmias. So similar to our skeletal muscles, cardiac muscles will also undergo depolarization and repolarization. Charged ions will move in and out of the cell in response to a stimulus or an impulse. If the impulse causes the electrical charge to reach threshold, the membrane potential will become less negative as a result of the movement of charged ions. After depolarization is completed, repolarization will occur and the movement of ions will cause the membrane potential to become more negative. So this is a reference slide that shows you a visual representation of what depolarization and repolarization are. So our cardiac cells have a cell membrane, and that cell membrane carries a charge. This charge is called our resting membrane potential. Under normal circumstances, resting membrane potential is negative 70 millivolts. A stimulus will come along and change the membrane potential. In order for depolarization to occur, the stimulus must be great enough to push the membrane potential over negative 55 millivolts. This point at which depolarization can occur is referred to as threshold. With depolarization, there will be a rush of positively charged ions into the cardiac muscle cell. Once depolarization stops, repolarization will occur. Repolarization involves a rush of positively charged potassium ions out of the cardiac muscle cell, and this causes the membrane potential to become more negative. And then here's another image that shows the flow of sodium and potassium ions that occurs during depolarization and repolarization. On the inside of the cell, there will be more potassium ions, and on the outside of the cell, there will be more sodium ions. The difference in concentration of these two ions is what causes the membrane to have a negative charge at rest. Our hearts beat at a rapid yet steady rate. In order for our hearts to be in unison, the myocardial cells must be able to communicate with each other very fast. Gap junctions allow for that rapid conduction of depolarization and repolarizing action potentials. It is important to remember that atrial and ventricular cells are separated to allow for effective filling of their respective chambers. If both the atrium and ventricle were stimulated to contract at the same time, blood would not have time to fill each chamber and wouldn't be able to be pumped around the body as needed. So this is our heart's intrinsic conduction system, meaning that the nerves within this system will be able to fire and maintain a heartbeat even if they were severed from the rest of our nervous system. This is because the heart has its own pacemaker cells, nervous structures, and electrical impulses. Our intrinsic conduction system begins with the sinoatrial node, or SA node. This is our pacemaker and generates the initial impulse that starts a heartbeat and determines our heart rate. The initial stimulus starts in the SA node and stimulates our atria to contract simultaneously. The impulse then travels down to the atrioventricular node where it will pause for 1/10 of a second. This pause allows for the atria to finish contraction before the ventricles will contract themselves, ensuring all the blood in the atria has been ejected into the ventricles. After this pause, the AV node then conducts the signal down to the atrioventricular bundle, which will separate into left and right bundle branches and the interventricular septum. This signal will then terminate in the subadenocardiocardial conduction network, also known as Purkinje fibers. At this point, the ventricle will be stimulated to contract. One important feature of the heart is that the myocardium behaves as a single unit. This phenomenon is known as functional syncytium. This simply means that all the cells within the atria will contract together and all the cells of the ventricles will contract together at the same time. The special gap junctions between individual cells and the conduction delay between the SA and AV node allow for this to happen. The heart generates a very strong electrical impulse that can be detected all throughout the body. An electrocardiogram or ECG or EKG can detect, measure, and record these impulses. However, it does not detect the contractile events. So we must make assumptions as to what is physically happening in the heart. In other words, ECGs can see the signals associated with cardiac events, but not the actual event itself. Here's an example of an ECG of a normal, healthy heartbeat. Notice that there is a sequence with clear pauses between waves. These pauses show that contraction does happen sequentially and not all at the same time. So during the first wave, our P wave, we will see atrial depolarization. Then during our QRS complex, we will see ventricular depolarization. We will also experience atrial repolarization during this time, but the signal is hidden by the larger signal of ventricular depolarization. And then lastly, we have our T wave, which represents ventricular repolarization. We will also see segments and intervals on our ECG readouts. Segments are flat portions indicating that the membrane potential is at resting potential or that there is a pause in the conduction at that point. Intervals will have a baseline segment and a wave included. This chart covers all the sections of an ECG and their associated boundaries. When we see the word deflection, that just means that the membrane potential is moving away from baseline. I highly recommend studying this chart as well as the previous slide to be able to label an ECG and all of its parts. And then this chart describes some examples of abnormal ECG readings and their clinical significance. So if someone presents an enlarged R wave, this typically means that the ventricular depolarization is too strong. This is indicative of an enlarged ventricles, and this just means that the myocardium is enlarged and results in a decrease in chamber size. A prolonged PR interval indicates a first degree heart block. It means that the pause between the SA node and the AV node is longer than normal. A prolonged QT interval means that depolarization and repolarization of the ventricles is taking too long. And then lastly, we have an ST segment that's elevated. So an elevated ST segment means that the ST segment on the ECG no longer occurs at baseline or at our resting membrane potential. And if the ST segment occurs above baseline, the heart is not able to rest during that time as it normally would. And this can indicate that a patient is having a heart attack. All right, so then here are some of our abnormal heart rates. So tachycardia is a fast heart rate, typically over 100 beats per minute. Bradycardia is a low heart rate, below 60 beats per minute. And then fibrillation is a rapid, uncoordinated heartbeat. It's important to know that neither tachycardia or bradycardia are pathological conditions. They are acute and they occur in small intervals of time. So like if you're exercising, you'll experience tachycardia because your heart rate will increase. Or if you're laying down at rest, completely at rest, like you're sitting in class or watching TV, you will experience a lower heart rate because it will typically be below 60 beats per minute. Neither one of these things in itself are bad, but prolonged tachycardia could progress to be a pathological condition known as fibrillation, which is characterized by rapid uncoordinated heart contractions. And then bradycardia in athletes is also indicates an increased efficiency of cardiac functioning because stroke volume, which is the amount of blood ejected by the ventricle with each contraction, increases with physical conditioning. The heart can contract more slowly and still meet circulatory demands. And then this diagram depicts everything that I just talked about, and it shows the relationship between each segment of an ECG and what is physically happening within the heart. So next, we'll cover the components of blood pressure. First, we will look at the events of the cardiac cycle. So first up, we have passive ventricular filling. This occurs when atrial pressure is greater than the ventricular pressure, and the AV valves are forced open. And blood will flow passively down from the atria into the ventricle. Next, we have active ventricular filling or ventricular filling with atrial contraction. This happens when the atria contract to complete the filling of the ventricle. Um, Ventricular diastole ends, and so the end of our diastolic volume. Next, we have our isovolumetric contraction. This is the contraction of, this is the beginning of ventricular contraction. Ventricular pressure increases and it will close our AV valves. Next, we have ventricular ejection. This happens when ventricular pressure continues to rise, causing the semilunar valves or SL valves to open and blood will be ejected from the heart. And then lastly, we have our isovolumetric relaxation. This happens when the ventricles relax, decreasing the pressure in the ventricles. That decreased pressure will cause the R semilunar valve to close. So then next we'll talk about our heart sounds. So our first heart sound is the lub, and that's the sound that happens when the AV valves close. Our second heart sound is the dub. That's the closing of our semilunar valves. And then lastly, we have S3, which we don't always hear, but that is just the filling of our ventricles. Murmurs may be present and they typically indicate improper valve closure or function. So our first sound, our lub, will occur during our isovolumetric contraction phase. Our second sound will happen during our isovolumetric relaxation phase. And then our third sound is not always present. So here we'll begin to tie everything together. We can see the heart sounds, pressure changes, and ventricular volume, all in relation to the ECG at the top. So look at this figure and think about some possible questions that I could ask you on your exam. And then walk through it very carefully. So things that could ask you are like, what is filling / contracting um, during our first heart sound? What is open and close during the second heart sound? What part of our ECG occurs during ventricular filling? Things like that are things that I'm going to ask you guys for. So lastly, we will talk about how to measure blood pressure with the blood pressure cuff. So typically, normal blood pressure is going to be around 120/70, ideally a little lower, but that is typical blood pressure is around 120/70. So when we use a blood pressure cuff, we will inflate the cuff above 120 to disrupt the flow of blood down the brachial artery. At this point, we will not hear any sounds. We will continue to release that pressure below 120 and we'll begin to hear sounds. That will be our systolic blood pressure. And then blood pressure reading ends when the cuff goes below 70 and we no longer hear sounds. That would be our diastolic blood pressure. So again, Systolic blood pressure is the pressure in the arteries when the ventricles are contracting. Diastolic blood pressure is pressure in the arteries when ventricles are relaxed. And then Korsakoff sounds are sounds made when blood is flowing through a newly opened vessel. That's it for this one, guys. I will see you in lab this week.